And we are going to hand this over to Trytten and John Richardson from the Iowa Hospital Association to talk about the Dimensions program through the Iowa Hospital Association that is available to Iowa and South Dakota hospitals. Go ahead, Kathy and John.
Thank you, Jen, and welcome to all participants on today's call. The Iowa Hospital Association is continually looking for ways to inform membership on tools and data potentials that are available to them. What we hope to accomplish today, you'll see on the slide that is presenting. We're going to review the history of the Dimensions program. It's actually been around for a very long time. We'll explain what the Dimensions tool offers, and John is going to provide an in-depth demonstration to allow you to see the immense capabilities that are at your fingertips. We'll try to offer ideas on how quality leaders can connect with Dimensions users in your facilities if you don't already know who that is, and then brainstorm ideas for expanded uses of these kinds of data in the quality world. What is Dimensions? It is an online tool that is available for hospital users to create reports from statewide databases, and that is the inpatient database and the outpatient database. This program is available to all IHA members and available to SDAHO members as well. There are minor differences between what is offered in each state, but for today's demo, we're going to use the Iowa experience where there are differences. I'll try to call them out. It's just that I might miss something. If you're a SDAHO member and need access or need to know any of the questions that are going to be put to the group, they are applicable to both state HIN participants. So the program itself has been around for a long time. It's offered as a data service since the 90s in Iowa, very much a different form at that time, and it has been through multiple upgrades and versions and potential platforms. Back in the 90s, we used a company called Cognos. And then in the 2000s, we brought, instead of partnering with Cognos as a way to manipulate the data in the back end to make it more usable, we worked with a development partner in Des Moines here to bring that into our own internal, into IHA internally. So at that time, it had a background that was called radio something. I can't even remember, to be honest. And so then in late 2000s, around 2010, we went with a platform called Grape City. That is the version that is available in the background where the data just spins and churns and is manipulated to show. It will become much more clear when you see the demo. In the early 2000s, the program was adopted by the South Dakota Hospital Association and has been in use with your members in varying stages, sometimes just inpatient, and this is where there's a difference. Outpatient has been available in Iowa for a very long time. In South Dakota, it's been offered at varying stages, with now all outpatient being made available. I would say that for the most part, the South Dakota experience that focuses on inpatient, but I'm not 1,000% if that's really the truth. So significant changes were made in 2010, as I just mentioned, because at that time we went with a new back-end platform, the Grape City that I talked about. And in 2018, we are getting ready to introduce even some more enhancements. We aren't partnering with a new vendor or anything, but we're making some increased availability of data sets that are packaged in a way that are what members and our state partners tell us might be easier ways to mine data, to understand, and to make it useful. Before I go any farther, Jen, are there questions on the chat or?
Hi, Kathy, it's Lana. There are no questions currently.
Thank you so much. Okay, how are these data released? This is a difference between states. In Iowa, it is released in the Dimensions program on a quarterly basis. Both states actually release data in multiple ways. This happens to be one of them. In approximately 90 days after the end of a quarter, we publish a new quarter and let our membership know that that is available. In South Dakota, it's released biannually. So around November, the first half of the year is published. And in May, the complete calendar year of the year preceding is made available in that way. So this is one of the places where there is a difference between states. John's going to really get into both of these tools. The actual program contains modules that allow different paths to get different outputs. In the what we call point and click, it's a wizard tool. We're fond of saying it's like a TurboTax or you can't do it wrong. So that allows you to get to standardized reports. Many of the hospitals that we work with use point and click reports for board meetings, standing item, agenda items at their internal admin or administrative staff meetings and things like that. So the point and click is, again, a wizard style that has standardized report templates that are available. Dimension Slice and Dice is a pivot tool, pivot style tool, and in data world is called an OLAP tool that allows you to flexibly query data. We make what are available that are called attributes and some measures that allow you to pretty much name or devise what your output, what you want your output to be. There are many, many options here that you will be able to see when John demos. So why do hospitals use these data? The source of the data comes from the collection of claims data. So once a claim is generated for each facility, both states are required to submit them per, both of us have a mandate. That mandate might be a little bit different in South Dakota than Iowa, but the responsibility is that these are data that are required for submission. The South Dakota Association and the Iowa Hospital Association are named the repositories for the state. In Iowa, we share our statewide quarterly data with the Department of Public Health. It acts as, we fulfill the responsibility for users to submit this data to the state. and it decreases the duplication of IHA collecting it and the state collecting it. We've also been able to increase the quality immensely since we have undertaken this since 2003. So these data are used for market share. If you know where your patients are coming from and you have a defined market share, those are things that you can set up and save in either of the tools that John is going to show. Service line analysis, I always use the example that if your market, whatever your defined market is for your counties and or zip codes or multiple counties, whatever your market is, you can count the number of hand surgeries done at the hospitals in your state. If that volume matches a significant number, it might be that that you go and actively seek a specialist in hand surgery to make monthly visits or have a monthly clinic. So service line analysis. It also helps for understanding where your market people are going for services that you potentially might not offer at your facility. Physicians are part of the Dimensions tool. The attending and the surgeon are provided, and you can observe those practice patterns as they're as it is available there. You can trend patient activity from one time frame to another. We try to optimize the program so that there are enough years or enough quarters available to be meaningful, but limit them so that pulling data doesn't get bogged down and that the resources are available to make the report appear in a quite quick, fast way. So there are ways to determine average charge and average length of stay. It's on the collection side, we work really hard to maximize the accuracy of the data so that these calculations will help your facility determine where you stand potentially with other with other hospitals in your state. There is some limited quality information available, and part of what we're going to talk about after the demo would be minimally what's available, but also would like to explore some new ideas that we're considering. There are additional resources besides the point and click and slice and dice report builders. There are manuals if statewide reports are available. PODs or patient origin and destination studies are posted here. John does a great job of providing training videos, and new are some report building guidelines that help those people that might be a little bit new to the program to understand how to use the point and click and slice and dice features. Data dictionaries allow you to understand the data, and then what we call README or data release notes tell the end user where there are challenges in collecting the data. Maybe one facility had changed their vendor and are missing half a month of their emergency rooms because they were not available by the time the quarter closed. And so those kinds of things in the volume world and accuracy and quality world are made known on the README so that the end user knows when they're looking at data results that differences in volumes might have a reason that is not otherwise noted, immediately. You wouldn't know why. So I am going to turn it over to John, and while he's switching, I will ask if there are any questions. You should be able to see the screen. John is starting in the slice and dice tool. We'll come back to do a demo of point and click after we get through this side, but I'll turn it over to John.
Thanks, Kathy, and thanks IHC for having us on the call today to show our Dimensions product. Like Kathy mentioned, this is the slice and dice portion of the tool. There's actually multiple cubes. I'll jump out so that you can see. So these are just different sets of data, the inpatient, inpatient all procedures, and then there's 3 different outpatient sets of data as well. Each of them are similar but different and contain different attributes within each one. I'm going to go ahead and jump into the inpatient one. Just it probably has the most relevant information to quality. So you'll see when we first jump in here to the inpatient data set that name and calendar year are automatically populated. That's the same in every cube. You'll see that all 118 hospitals in Iowa are included here, as well as Dakota Dunes, which is a South Dakota hospital right on the border. For our purposes today, I'm actually going to go ahead and drag name out so that we can see more aggregate data. You'll see what's displayed now is discharges by calendar year. So 2011, there were 347,600 discharges all the way up through. We have 3/4 of 2017 data currently in here. And you'll see that it's significantly less than 2016 calendar year because of that. So we anticipate when we do finalize our 4th quarter data and publish, you'll see calendar year 2017 data in here. And the counts will obviously rise. So over here on the left are all the attributes that you can actually drag and drop into the grid here. And you'll notice when I take, say, for example, age ranges, and I pull it into the grid, in the rows, it's going to populate all those discharges by age groups. And it's such a customizable tool. You could put age ranges up top here, and it's going to give you a different view, but you're still looking at the same information. So part of what you can do in the slice and dice tool is look at your real or your race, ethnicity, age, and in the future language, which we'll be collecting starting with 1st quarter 2018 data in Iowa. So currently I have the age, so we could go ahead and drag ethnicity in. And you'll see that you can now look at your aggregate data, and this is all aggregate, but you could do it by hospital. You can filter on hospital. You can include, only certain market areas. You'll see that it's broken down discharges now by age group over here on the left, and then ethnicity in the top. If we wanted to drag that out and we didn't want to look at ethnicity, but say we wanted to look at race, we can go over here to our attributes, find the race attribute, and we can drag that in to the rows. And for easy use here, I'm going to drag age up into the columns. So now you're seeing all of your different races over here on the far left. And then your age ranges up the top and your calendar year as well. So obviously you can do a lot with this tool. I'm going to drag the age and the race actually back out. But in Iowa, when we do add language, it will be another attribute, same as race or ethnicity or age range, where you could drag it in and then do your reporting based on that. So one of the quality features that is included is the APR DRGs. So you'll notice when I drag these into the rows here that it throws up all of the APR DRGs from 001 all the way down through 956, which is ungroupable. So if you wanted to look at your APR DRGs and then say bring in your severity index to give you an idea of how many resources are used per APR DRG, so you're looking at, I'm actually going to go ahead and filter on calendar year here just so that we are all looking at the same year. So now you'll see it gives you each APR DRG and the count of discharges at each level. So for example, take 002, which is heart and or lung transplants. It looks like 12 of them were extreme, so the majority of them, over half, took a lot of resources. And then 10 of them took a lot of resources, but not quite as much as extreme. And then very few of these APR-DRGs or this procedure requires very little resources. So that is one way that you can look at the data in here and kind of gauge it. And you can do this by hospital. When you're in these inpatient or outpatient cubes, you're not limited to only looking at your data. You can look at data like we are currently on a statewide level. You could look at, maybe a competing hospitals level, their data. So it is very robust in what you can do. And the more you're in here, the easier it gets and the more useful the data becomes. So that's kind of the slice and dice portion. And you'll notice down here, we have the measures. So measures are actually going to be more counts of dollars instead of discharges or visits. You'll see that if I expand this right here, you'll see that we have average charge per discharge, average charge per day, and then revenue centers, as well as some total charges. You'll see room charges there, total charges without professional fees. So I could actually drag in, let's say, average charge per discharge and put it with the APR-DRGs. It's going to throw up a graph because I actually should have put it in the data box. So now it'll give you an actual average charge per discharge for by APR-DRG. So we were looking at heart and lung transplants. Obviously, that's a very high charge procedure at $821,542 on the statewide level. So you can get down to some very, very useful information. You'll see over here we have MSDRGs, so you can get down to an MSDRG level, similar to the APR-DRGs. You could look at it, the average charge per day or per discharge at the MSDRG level as well. We also include principal diagnosis, principal procedure, priority of admission, procedure, physician. So you could look at the physician level. You can get an average charge per discharge by physicians to see, your high chargers or your low chargers. But obviously, you can really, really manipulate the data into whatever you want to look at in the slice and dice tool. So I'll stop and see if there are any questions on the slice and dice app before I move into the point and click.
Everyone, please remember you can use the chat box if you have any questions at any time, and we can get those to John and Kathy for some response. One question I have, and maybe you've addressed it or maybe you plan to, but who should be the user for the Dimensions application in the hospitals?
So it really varies. A lot of our users are marketing. They use it to get a market share, to figure out if they need to add a service or they need to maybe get rid of a service if they're seeing that it's underutilized. But it really is open to anybody at the hospital can be a user of Dimensions. They would just have to go through their access administrator to be approved.
And John, can there be multiple users to the Dimension product then at each hospital?
Yep, there certainly can be. I would say most of our hospitals actually do have multiple users.
And one question, John, we have right now in the chat box is, how do we find out who has access to the Dimensions program within their own facility?
That's a great question, Lana. It is actually something we can talk about in a future slide, but this is a common question. For the persons on the call, we would ask that you contact your improvement advisor. They will connect you with John or myself so that we can alert you to who at your facility is an active user of the program, and we'd be happy to provide that information back.
Thank you, Kathy. Are there any other questions you can think of right now? I do have a question myself, Kathy and John. you indicated that this information will show the statewide data for each hospital, or they can break it down into their own hospital. Did I miss something on how that's done, just so they can look at their own hospital, or how does that look? If I want to just look at, let's say, Mount St. Christopher in Willamazoo.
Yeah, I can go ahead and show that. Keep in mind we're in Iowa's dimensions, so we don't have any outside hospitals outside of Iowa included, except for Dakota Dunes. So I guess to show that, I'll go ahead and filter on Dakota Dunes, just to give everybody an idea how you do that. So over here under the attributes, there is a hospital tab, which you can expand, and all these tabs on the left can be expanded to show their different levels. Under hospital, we have by class, by control, and by district. Those probably don't mean a whole lot to you, but by class is kind of whether they're urban, rural referral, or a critical access hospital. The by district or by the Iowa districts, which is just kind of how we break down our members. And then by name. So if I were to drag name in here, you'll see that it'll throw up a filter box that includes all hospitals in Iowa. And I can scroll all the way to the bottom. They're organized by city name. So if I go up here to Dakota Dunes, select that only, click OK, you'll see that now name appears in the filter box. And if I drag it into the rows here before APR-DRGs, it's going to display Dakota Dunes as what we're looking at, and then it breaks it down by all of the APR-DRGs that were used at Dakota Dunes in this given time period, which right now we're looking at calendar year 2016.
I appreciate you showing that, John. I'm just thinking from a quality perspective, it would make sense that we have our quality people who could gain some access to the dimensions, because with some of the performance improvement projects that they're implementing, they could even look at prior costs and show improvement with costs on an annual basis based on what I'm seeing here today.
That would be true. I just want to caution, cost is not part of what we show. We do show total charge. Obviously, in a data world, that's a distinction that you're going to want to make. What we apply to one hospital that we apply to everyone, so a comparative is available.
Thanks for that clarity, Kathy. That truly makes sense. I appreciate that.
Okay.
So I'm going to go ahead and move on to the point and click. If you do have any more questions on the slice and dice, feel free to type those into the chat box and we'll come back and answer those. So like we mentioned, Dimensions is a tool program. It consists of slice and dice, which I've just shown you, and the point and click. So I'm going to go ahead and jump into the point and click part of Dimensions now. And you'll see when I selected point and click that it takes me to this select patient type screen. This will be the screen that you will see every time you click on point and click. It gives you the option of choosing whether you want to look at data by inpatient data or by outpatient data. For our demo purposes here, we will just select inpatient data. Click on next. And you'll see up here in this summary box that I'm going to highlight that we just selected patient type, and so it throws inpatient into that box. As we move along, keep an eye on that. It will grow and it will tell you everything that you've selected up until that point that it's building your report on. So here's where you'll select the template. You have the option of choosing it by discharges, days, and average length of stay. And you can see over here on the right, when I hover over it, it kind of gives you an example of what that will look like in your end report. You also have the option of doing a market and facility report, which is comparing your market area to your actual hospital. So in this market area, there were maybe 500 discharges. Of those 500 discharges, 200 of them went to your hospital, something like that. You could do it by measures, which are kind of the things that were on the bottom half of the slice and dice on the left. And then you can do your trending market and facility reports for 3 years by quarter, or for 4 quarters. So we're going to go ahead and choose a market and facility report. Click next. Here's where you'll select your facility. I'm logged in as myself, which is an administrator of the program, so I have access to all hospital data. But if you gain access to this program, you only have access to your hospital. So again, we'll just go ahead and choose Dakota Dunes. Click next, and you'll see the summary keeps growing. We selected inpatient, our market and facility report, and now we've selected Dunes Surgical Hospital. And this is the point in building the report where you will either choose whether you want to look at your market area or if you want to look at a peer group, which would be a custom selection of like-sized or hospitals in your area. For this one, it just makes more sense. We'll go ahead and do a market area. You'll be brought to this screen where you create your market area and you give it your market area name. So we'll name this IHC Demo HIN. And you can select counties, so I can throw Adair County over here, or you can select zip codes, certain zip codes within a county. So if I only wanted to include, say, maybe the first 5 zip codes here, click those. Now we have a market area consisting of Adair County and then these zip codes in Alamaki County.
Whatever that is.
I'm not sure where those are, or maybe some counties that are around Dakota Dunes. So I'm actually just going to take a large selection of counties so that we have data to show. So now we have a selection of counties as well as these, looks like 6 different zip codes. We've given our market area a name, so we'll click next. You'll see that it throws the market area, the name that we just gave it up here under the summary. And then you're brought to this screen where it's going to show you what is shown as rows on your report. So you could do, your age ranges, which would be that 0 to 18, 18 to, I think, 35 or something like that, and so on. You could do it by your APR-DRG severity index, which is what I showed you in Slice and Dice, or your APR-DRGs just in general. You could have a list of facilities on the left, your MDCs, MSDRGs. Obviously, you could break it down by payer. You could look at your attending or procedure physicians, product line, which is what we're going to select for this example, or you could do it by state, county, zip, so it will break it down by those counties. Click next, and we're just about to the end of building our report. This is where we would select additional filters. So for example, if we only wanted to look at data that included male or female data, we would just select those and only female data would be included. I'm going to deselect that actually. If we only wanted to look at, say, your 65 and older elderly care, you could certainly look at elderly data and 65 and 75-year-olds would be shown. We're not going to limit our data set at all for this report. So we're going to click next. Here's where you'll select the time period. Obviously from Slice and Dice, you could see that we included data all the way back to 2011. That is also true with Point and Click. So we'll select 2011 Q1, and we'll go 2 years. We'll go up through 2012 Q4. We'll be brought to this screen where it kind of shows you everything. You can make sure that everything that you want included in your report has been included, that you don't have any additional filters applied. And then if everything looks good, you can go ahead and give your report a name. And then you can select if you want to look at it as an Excel document, as a PDF, or as a Word document. I would suggest Excel or PDF are the most commonly used formats. So click Save. You'll be brought to this screen, which is just a pending report screen, meaning it's in the queue, it's being built. And then whenever your report has been built, it will disappear from this screen. Usually doesn't take more than 30 seconds to a minute. And I'll go ahead and click on the user report screen. It's still in the queue, but when it does appear, you'll notice that it'll appear here. They go by created date, so it will be at the top. And then you'll see that I only selected PDF, so it'll be shown kind of like this first report that is up here.
The biggest difference between what John is showing you now in point and click and the slice and dice is the customizability. The point and click reports are canned, standardized templates where the columns at the top and the rows, while you can select what data you want to show, it's limited by some factors in here that allow that template to show what you want.
So you'll see that the report that was under here disappeared from the screen. That means that it's been processed and that it's waiting for you to look at. So here is the report that we just created, the IHC HIN demo. And I also would like to note, if you're at a hospital that is a heavy user of Dimensions, it will show any other user at Dimensions that is in Dimensions that has created a report from your hospital. So I'm going to go ahead and click on the PDF report here. It'll pop up down on the left. And obviously Dunes was a bad example because they don't have any discharges in that market area that we selected. But if they did, it would show up here, say if they had some adverse effects discharges, it would show up here as 5509 discharges in that market area that we selected. And then however many Dunes had would be shown here. It would show their length of stay, their average length of stay, and their average charges for that product line, as well as their market share. So again, I apologize for that bad example, but I think you can get a good idea of just how useful a simple report like this could be in your meetings or a board meeting or any of that nature. So you've seen how a point and click report has been built. Are there any questions?
Essentially, those reports then remain in that queue until someone goes in to actually delete it. Is that correct?
So the queue is just where your reports, it's kind of like a limbo. It means they're being built, and then once they're built, they'll go into the user report screen, and they'll stay there until somebody deletes them.
Okay.
So I did pull up another example that I've created recently. You'll see that Broadlawns Medical Center here in Des Moines is one of the ones that we're looking at, as well as a market area. It looks like that includes some Des Moines counties. So you'll see, let's take, for example, down here, psychiatry. In our market area that we had created, there were 3,922 discharges. And of those 3,922, 514 went to Broadlawns for psychiatry, which gives them a 13.1% market share.
Any questions? We could go back to the PowerPoint and so there are some new things coming within the cubes that will be launched in both Iowa and South Dakota sometime in 2018. We're including an inpatient-outpatient combined cube. We changed some of the way that revenue centers are displayed and realigned them to be more up to date with today's billing practices. We're really excited about unique patient count. It allows, if you're looking at discharges, say in the slice and dice grid that John showed, and you bring in unique patient count as another measure, it allows you to see that for the time frame and for whatever specialty or market you're looking at, that the number of discharges might be, I'll just use a small example, there might be 100 discharges, but unique patient count might be 83, which means of the 100 discharges, 17 of them had two, or there could be multiples. One patient might be included more than one time. So we're excited about that. The other changes that you see that are coming will impact those Dimensions users that already exist, and they will be available if you're interested in becoming a user of the program. So, John showed some examples about I said at the outset that we have limited quality, but some of the things that you can do with this data is understand what your community needs might be. For what your market are, you're going to understand your diversity with race, ethnicity, age, and soon-to-be language. If the severity index on the APR does offer a way to see where those more intense type admissions are, and obviously a predominance of critical access hospitals, that may or may not be useful, but it is something that is available in the current tool. I already explained examining the real race, ethnicity, age, and language results. And then we are exploring additional or expanded uses of the claims data in some new tools that we're going to, that we're considering for inclusion in the Dimensions program, which would allow us to show some drill down readmission information. Obviously, you're used to seeing your Compass HIN results for the ARC, IQI, and PSI grouper outputs for some expanded hospital acquired condition or HAC reporting. And so these are things that are in the works. We hope to be able to share exciting things in 2018. And I guess I would like to open it up now to see if there are questions and other ideas that potentially could be used by the quality professionals. At the outset, I also did say that Dimensions is one of the tools or one of the ways we release these data. In Iowa, we offer what's called CHIME maps. So it allows a drill down capability to street level for your own data, or at an aggregate zip code level for all states, the state, and it allows you to compartmentalize or examine community needs, where there are hot spotting of a specific patient. In the current Dimensions program, it does not allow to get to record level so that you could identify a patient. The purpose of that tool is not to allow that. Okay. Okay, that's a really great question. The severity on MSDRGs is a little bit complicated. For every type of MSDRG, there are 3 options. There's a, I'm trying to think of, I'm going to use a very elementary, and I'm using the wrong words. They will not apply to anything you would see related to MSDRG. Yeah, John's going to go there and bring it up. So let's say that we talk about pneumonia. There are typically 3 MSDRGs related to a specific pneumonia MSDRG. The first one is without comorbidity, without, John, if you pull that into the MSDRG into the filter, see if we can find some. So the first one is the low level or low intensity, where you have to go over to the right though. So see where it says with MCC, that's with major comorbidity and complication. With CC is with comorbidity and complication. And then some MSDRGs have without comorbidity or complication. So you really have to be aware of, so highlight this one right there, the pneumothorax without CC or major complication. That would be the low level. Then there can be a pneumothorax with with complication or comorbidity. And the final one, the one that's the more resource intense, is with major complication and comorbidity. I think that this is a great question to go to a higher level. When you're using these kinds of data, it would be to your benefit to educate yourself on questions just like this. We try to give tips and tricks that are like this for users that are frequently in here. A lot of times the people that are doing market analyses would never get to that level to ask that question. So I really appreciate that you brought that forward. Are there any, while we've got the program up, are there any other questions?
Kathy and John, we don't see any further questions at this time. Okay. Just want to thank you so much for the presentation today. So is this your final slide that you have here that you want to speak to?
Yes, and we welcome the chance to do individual demonstrations, or if you do have questions about the program, specific ones, if you're already added as a user, you can, John or myself are available for questions about specifics. This program has been around for a long time, but we're constantly amazed at how there are pockets of people, staff at hospitals that don't know it exists. It's an invaluable tool for data mining, for decision making, and for strategic planning that hospitals have access to. So we welcome the chance to help answer your questions. If you want to know who your Dimensions contact at your facility is, please reach out to your improvement advisor. They can forward that to John or myself, and we can provide that information for you. We do have a new process to bring new people into the program, so it would be filling out a form from the person at your facility designated as the access administrator. And so that will be what we would start the process of to get you into the program.
John and Kathy, thank you so much for your presentation today. We really appreciate your time and the information that's been shared with our participants today on our learning community. So everyone, at this time, we are going to take about a 10-minute break. We will resume at 10:20. Do not log off. We'll just continue, we're just going to take a break. We want to get set up for our next presenters, do sound checks, and make sure we have all their information ready. So again, we will start again and resume at 10:20 a.m. Thank you so much. Hey everyone, this is Lana. We're just going to do sound checks real quick with our next presenters. Lori, can you hear me okay? And can you just speak up so we can assure we can hear you? And Joan, can you hear us okay? And Kathy, we need to do a sound check with you. We want to make sure that you've dialed in. It'll be the best way for us to assure we can maintain the connection. If your line is muted, go ahead and unmute it, and I can check on my end. Okay, Joan, let's do a sound check. Can you hear us? And can you just verify so we can make sure we hear you? Lori and Kathy, can you hear us okay? And can you verify that we can hear you?
Thank you, everybody, for your patience. We're just getting our next speakers here. We're running into some technology issues, and we'll get started in just a minute.